Thank you, George, Bernard, ladies and gentlemen. Before starting, let me apologize for two things. First of all, different from the two preceding speakers, I will not be able to present so many data and so many papers. And this is because it seems that scientists are not so much interested in the tricuspid valve. And the second reason is that since no one seems to be interested in the tricuspid valve, we decided to adopt that. And knowing better the valve, I really fell in love with this valve. So Bernard, George, stop me at a certain time because, as you know, when you talk about your lover, you go on and go on for hours. Why it's not so well treated, the tricuspid valve? Well, first of all, as any lady, when you look at the tricuspid valve with the 2D images, it is quite mysterious since you are doesn't matter if you approach hit by transthoracic or transesophageal approach, and doesn't matter which view you use, you are almost always able just to see two leaflets. And sometimes these, the exact leaflet that you are looking at, it's not so certain, and you have to sweep your probe backward and forward to realize that. But when you know it better and you approach it with a 3D echocardiography, you realize that this mysterious valve, that it cannot be seen on face as we usually do with the mitral and aorta with the 2D, becomes much less mysterious. And you can have this nice view of the leaflets and the commissures in the large majority of patients. And this is nice because 3D now provides us the opportunity to look at the valve from two different perspectives on face, from the atrial perspective, that is the surgical view, and from the left ventricular perspective, you can see the leaflet, the septal leaflet, the anterior leaflet, the posterior leaflet, and this is the right ventricular outflow tract, and here is the pulmonary valve. This is the interventricular septum and the mitral. And as you see, the anatomical detail that we can obtain with the current 3D technology is quite close to the anatomic specimen that have provided me by our friends, the anatomists, with a small but not negligible difference, at least from the patient point of view. This is an alive patient with whom you are able to speak, and this is unfortunately a patient that has passed away. And and not only you can get nice images of the valve, but you can also explore the entire tricuspid apparatus, looking at the position and the function of the papillary muscles as well as the chordae. And not only, but as we have seen in the previous session, we can also have an accurate assessment of the cardiac chambers that are upward and downward the tricuspid valve, like the right ventricle and the right atrium. So having this nice way of looking at the tricuspid valve, we were first interested to look at the anatomy of the tricuspid valve. And the first question was, but actually, how many leaflets does the tricuspid valve have? And we have seen that in some cases there are just two leaflets. In some cases, leaflets are 4. But luckily, in the majority of cases, they are 3, and so we can continue to call it the tricuspid valve. Professor Lang showed me a paper by an Indian anatomist that was able to find a valve with 6, tricuspid valve with 6 leaflets, so it's quite a variable anatomy. It's important from the clinical perspective, yes. It is, and I show you 2 brief cases just to support my statement. This is a 40-year-old gentleman who underwent non-cardiac surgery, cholecystectomy, and during the operation developed atrial fibrillation. And on the ECG, there was a right bundle branch block. And as part of the post-operative workout, he underwent ambulatory ECG that showed a non-sustained ventricular tachycardia run 9 beats. And then an echo that showed the right ventricular enlargement and severe TR. Now, you are in Padua. You have an enlarged right ventricle and non-sustained ventricular tachycardia. So you have a high suspicion to have a arrhythmogenic right ventricular cardiomyopathy, and you have to prove not having it before being released. And so the patient was referred to our echo lab to have a more comprehensive echo assessment with this clinical suspicion. And you can see the 2D images showing enlarged right atrium and right ventricle, tethered tricuspid valve leaflets, and what it is, no doubt, a severe tricuspid regurgitation. And the patient said, yes, I know that I had an enlarged heart with a murmur since when I was young, but I was also an athlete, and everybody says me that I have an athlete heart. And so based on these images, you can think to fix these as a functional tricuspid regurgitation with a tricuspid valve annuloplasty. But if you don't, you are not happy with these images, but you acquire a 3D images, you realize that there are just 2 leaflets that are tethered in this unfaced view from the ventricle or in this longitudinal view. But one of the leaflets that was not apparent with the conventional 2D images indeed is flailing with the ruptured cord. And so we interrogated again the patient, and have you had any trauma, any endocarditis, whatever it is? And he said, no, no, no. But then he said, oh, I remember that when I was 15, I was caught in a tornado and smashed against the wall of my house. And indeed, looking more carefully at the chest X-ray, you have the healed rib fracture. So probably this is the result of a long-standing traumatic rupture of tricuspid leaflet with regurgitation, and the planning for this gentleman changed completely, and not anymore tricuspid annuloplasty, but tricuspid valve replacement that was successfully carried out. In other cases, very short, this is a severe tricuspid regurgitation. There is something obviously that is going wrong with this valve. But if I ask the audience which is the flailing leaflets, probably I have a split of the audience in 3. 1/3 for the septal, 1/3 for the anterior, and 1/3 for the posterior. And this is because we have not a comprehensive view at the valve. But if we got this type of images, an unfaced view of the valve from the atrial perspective, everyone in the audience can easily identify the flailing of the anterior leaflet. And this is not because in this audience there are bad echocardiographers, but because it is objectively difficult. And it was documented by these elegant demonstrations by Ivan Stankovic from Belgrade that presented last year at EuroEcho. Look at these 4-chamber views. They are obtained from a 3D data sets. And there is no major difference between the two. Difficult if you look at them separately to say, okay, this is not a good 4-chamber view. But this one, the 2 leaflets are the septal and the anterior, and in this one, this is the septal and the posterior. So difficult from conventional to the echo to look. And when you use the short axis view from the parasternal approach, things that doesn't improve so much. Again, 2 quite similar short axis view centered on the tricuspid valve, but this time you have the septal and the posterior leaflet, and this time this is the anterior and this is the posterior. So it is objectively difficult when you just see 2 out of 3. For the sake of time, I want just to discuss the additional value of 3D echocardiography in functional regurgitation. And this is a good example of a patient with functional regurgitation with lack of cooptation of the leaflet. You see the residual orifice from this view from the ventricle, as well as from the same patient looking at the valve from the right ventricle. The leaflets are tethered, a little bit thickened, and they don't co-opt. This is a patient with obvious functional tricuspid regurgitation. This is severe, sorry for the flash on this size. What we want is first to quantitate the regurgitation. And what we usually do for that is using the vena contracta of the regurgitant jet, as well as the radius of the PISA. These are two of the semi-quantitative parameters that are in the guidelines. However, when you use these two parameters, we assume that the orifice of the tricuspid regurgitation is rounded. And this is a basic assumption that then to allow us from a diameter to think to an orifice. But indeed, when you look at the valve in 3D, you see that in functional regurgitation, more than 90% of patients have a slit-like or a fissure-like orifice. It is never rounded. And this is well explained by this view. This is the unfaced view of the vena contracta from the atrial perspective. And these are two cuts. The red one is the direction of the four-chamber view, and you see that here there is this vena contracta that may be mild or moderate. But if you cut the same vena contracta in an orthogonal view, the yellow square, you see that the diameter is much larger. This is definitely a severe one. And having the average between the two doesn't improve your assessment. So what you can do with the 3D is just to acquire the 3D data set of the regurgitant jet, and then to slice this data set in a number of slices to identify the smallest of the vena contracta and making a planimetry. This is an objective assessment independent of any geometrical assumptions of the severity of the regurgitation. Velayudan and co-workers did it and proposed a sort of scoring for the grades of severity. I'm not aware of any validation of this grading, but I have seen a paper from the Mayo Clinic, Sunil Mankad, that have validated this approach, and the paper will appear soon in the Journal of American Society of Echo. The only issue with this approach is that the size of the vena contracta is really dependent on the gain regulation. So you should be really good in regulating your gain, because otherwise you will under or overestimate. And an additional tool that we can get from a 3D echocardiography is the ability to quantitate the PISA, the 3D PISA, and so doing a quantitative assessment of the area of the regurgitation without any assumptions about the shape of the regurgitant orifice. This is a quantitation that is independent on the shape, and can be not just one shot at a certain point, but as you can see, it's dynamic. You can follow the changes of the regurgitant orifice throughout the cardiac cycle. And we did it, and Dr. Miglioranza did it in my institution, and he was able to show that like the mitral regurgitant orifice, also the tricuspid functional regurgitation is highly dynamic, having the highest regurgitant orifice area at the beginning of systole, then it decreases to get again higher to the end of systole. And so also this is an important message, that when we make our measurements of the vena contracta size at the mid-systole, we almost always underestimate the degree of the regurgitation, because this is the lowest of the regurgitant orifices. However, cardiac surgeons doesn't matter so much about the degree of the regurgitation. The important parameter for them is the size of the tricuspid annulus, and they know that if the tricuspid annulus is dilated, they have to fix the valve, otherwise, despite a successful intervention of left-sided valves, the degree of the regurgitation will evolve over the time. And what we usually do with the 2D is to provide this diameter of the tricuspid annulus in a focused right ventricular 2D view. But then the cardiac surgeons do not believe to us. And in doubt, they open the right atrium, put 4 fingers in the tricuspid annulus. If the 4 fingers pass, they fix the annulus. If the 4 fingers don't pass, they don't fix. This is, however, quite not objective, because if the surgeon is the lady in the first row, probably most of the patients have the annulus fixed, and if the surgeon is Mike Tyson, very few patients have the annulus fixed. So we have to provide more objective data. Why they don't believe to us? Because there is no anatomical landmark that in this view show us where we are. And this diameter is just one of the hundreds of thousands of diameters that we can take from the real tricuspid annulus as we see in 3D echocardiography. And when we have this unfaced view, we can have much more anatomically sound diameters. And by the way, you see that both the anteroposterior and the septolateral are higher than the one that I have measured from the 2D. Now we have better ways to assess the diameter, the annulus, and so we can also look at the dynamics of the annulus. And we and Dr. Muraro and Dr. Adezia, in a collaboration between Padua and Chicago, has performed this study measuring the mitral, the tricuspid annulus at different times during the cardiac cycles. And what they were able to show that it is really a highly dynamic structure. And if you look at the row of the area, you see that you have the highest value in the late diastole, so just before the valve starts to close, and then there is a changes of the area continuously throughout the cardiac cycle. And also, quite important, they show that the size of the annulus doesn't matter if you measure the area or the diameters, is related to the size of the right ventricle. So it seems that the cardiac chamber has an important influence on the size of the tricuspid annulus. However, measuring all these diameters and areas frame by frame throughout the cardiac cycles is just good for science, but cannot be applied for in the clinical practice. And so we need a software that is able to make a dynamic quantitation of the tricuspid annulus. And this has been developed by Federico Veronesi and co-workers, by the bioengineers in Bologna, that they provided this original software that we are going to validate and in the clinical work in a cooperation between the University of Padua, the University of Bologna, and the University of Chicago. Preliminary work showed that this software is able to really assess the different parameters describing the geometry of the tricuspid annulus, but not, and again showing the highly dynamic behavior of the tricuspid annulus throughout the cardiac cycle. But not only that, because the software is able to automatically tracking and tracing the leaflets, and so to provide the size and the position of the leaflets, and also providing a parametric color map of the displacement of the leaflets that may be helpful in the diagnosis. Not only the size, but also the shape of the annulus is important, and as its counterpart on the left side, the tricuspid annulus has a non-planar shape with a saddle shape, and this non-planarity become flatter and flatter as the degree of tricuspid regurgitation increases. And finally, when you look at the functional tricuspid regurgitation and you have to ask the surgeon to think about fixing the tricuspid valve while approaching the left side of the valves, you have to look at the determinants of the regurgitation. And more the tenting area and the tenting height that we use for the mitral, here in the tricuspid, for the tricuspid regurgitation, it's really important to assess the tenting volume, because with the 3 leaflets make it really difficult to assess the exact degree of displacement just looking at the planar displacement. And the tenting volume is important. Look at these 2 patients. Both of them has a similar annulus area, but one has a mild tricuspid regurgitation and the other one has a severe tricuspid regurgitation. And this is due because the tenting volume of the patient with severe tricuspid regurgitation is 3 times the one of the mild tricuspid regurgitation. And indeed, the group from Korea showed that the tenting volume of the tricuspid valve, together with the annulus size and the leaflet tenting, are the major determinant not only of the degree of the regurgitation in preoperative, but also of the relapse of tricuspid regurgitation after the tricuspid annuloplasty. So, ladies and gentlemen, hope that at the end of my presentation you can agree with me that being the fact that tricuspid regurgitation is a common echo finding in our patients, the identification of leaflet abnormalities is pivotal to discriminate between functional and organic tricuspid regurgitation that change the management of the patient. 3D echocardiography is unique in assessing the tricuspid valve in order to allow us to understand the mechanism of tricuspid regurgitation, quantitate the valve geometry and the relative importance of the different components of the valve apparatus, and to tailor the surgical treatment options accordingly, and all to predict the success and durability of repair. So it's essential that as we have with the mitral valve, we are able to develop a software that allows us to make all these measurements in the clinical practice. This is the end of the presentation, but if you want at the end of your echo think to develop more your skills in 3D echocardiography, please take into account that next September in Atlanta, Georgia, there will be a 2-day-and-a-half 3D echo course that you can attend. Thank you very much for your kind attention.